get started. Thank you all for joining the Department of Health for this technical briefing on monkeypox. I'm here to brief you today on the latest are State Health Officer Dr. Joseph Kanter, as well as State Epidemiologist Theresa Sokol. My team will drop those names and titles into the chat in case helpful. In terms of run a show, Dr. Kanter will start by walking through today's announcement and what it means. He'll provide some background on monkeypox, including the latest on the global and national situations. And then he'll speak to our guidance to anyone who has concerns of infection or exposure. He will then turn it over to Theresa, who will speak to what happens when there is a known exposure or case. And then finally, Dr. Kanter will provide a brief COVID update. And then we will open it up to questions for all of you. A little bit of housekeeping. One, please do put yourself on mute. Thank you to everybody who has done that proactively during the briefing and when you're not speaking. This is a technical briefing for members of the press. And so I hope everyone understands that those are the questions we will be taking today. If you do have a question and you're a member of the press, please include your name and the name of your media outlet in the chat, and my colleague Michelle will call on you when we get to the Q&A, so you can ask your question live. This is on the record for those who have sent me a message in the chat, but we do ask that you not live stream. We will be providing a recording afterward. It usually takes us about 30 minutes to get it up on YouTube. And so with that, I will be turning it over to Dr. Kanter.
Allie, thanks to you so much. Good afternoon, everyone. I'm very pleased to be joined by State Epidemiologist Theresa Sokol. I really hope everyone had a lovely holiday weekend and enjoyed the time with them or their family. What we'll be talking about today is monkeypox. And as you saw earlier, today, Louisiana is announcing our first identified case of monkeypox in a Louisiana resident. We have already had an identified case of monkeypox in a out-of-state resident who spent some amount of time in Louisiana and generated some exposures. And there certainly have already been Louisiana residents who have spent time in other states, been exposed to identified cases of monkeypox in other states, and then returned here. This is now the first identified case of monkeypox in a Louisiana resident. If you're keeping track of the CDC dashboard where they list the 35 odd states and territories that do have an identified case amongst one of their residents, we would expect Louisiana to show positive on that later today or tomorrow. I'm using the word identified case on purpose here because this is not unexpected right now. The widely held belief is that there is more monkeypox circulating in this country than has been formally identified and diagnosed. And there's a few reasons for that. Testing is not as widespread as it perhaps could be. There's a long incubation period on this. Some individuals might misinterpret their lesion for something else, and some individuals just might not go get checked out at a clinic or by a doctor at all. So there's a lot of reasons to believe that there certainly is monkeypox circulating that has not already been formally diagnosed. So in that respect, it was just a matter of time before we had our first identified case. This is not terribly unexpected for us. There's, as I said, about 35 states and territories that already have an identified case. Those collectively comprise over 600 formally identified cases in the US. There's currently over 7,000 formally identified cases worldwide. And those numbers are widely believed to be an underrepresentation of the true amount of monkeypox virus that is spread. Let's be clear for a second. This is not Ebola. This is not COVID. This is not expected to erupt into a worldwide pandemic that will grossly alter our way of life. That said, it is something important. It's something that we need to be paying attention to, and particularly for individuals that are in the highest risk category. They need to be taking precautions and have heightened awareness. That specific category is typically, for this virus and this outbreak in this country right now, men who have sex with men and have either multiple or anonymous sexual partners. That's the highest risk category right now. Those are the people that need to take the most precautions. If they have any symptoms that could be suggestive of monkeypox, they certainly need to refrain from intimate contact with others. And if they have any lesions that are concerning, they need to go immediately seek medical attention and be evaluated. Monkeypox is a rare disease caused by infection with the monkeypox virus. The monkeypox virus is a cousin of the smallpox virus. The symptoms are somewhat similar, although the symptoms and the manifestations for monkeypox are much, much milder than smallpox. Monkeypox is rarely fatal. There have been no fatalities in the 600 odd cases identified to date in the US. In underdeveloped countries that don't have as robust medical systems as the US, namely some West and Central African nations, there have been fatalities from monkeypox in the past. The US has had small monkeypox outbreaks in years past and isolated to a few states. It's very rare, next to unheard of, to have a fatality in a highly developed and advanced medical system like in the US. Doesn't mean that that's not impossible. And one of our fears is that if an individual gets monkeypox who has significant underlying conditions, if they're immunosuppressed or something similar, they might have a severe outcome. To date, there have been no fatalities linked to this outbreak in the US. The classic symptoms of monkeypox can include fever, headache, muscle aches and backache, swollen lymph nodes, those are nodules on the body, chills, exhaustion, or rash that can look like pimples or blisters that can appear really on any part of the body, whether it be the face, inside the mouth, or other parts of the body like the hands, feet, chest, anus, or genitalia. I'll tell you, if you go right now and Google monkeypox, what you're likely to see is pictures of individuals from West and Central Africa covered in very frightening looking lesions. That's not how most of the cases in this domestic outbreak are presenting. Many people are presenting with lesions limited to one part of the body, oftentimes the genital area, but not always. And many people are presenting without the typical, what we call viral prodrome, without the fever, headache, muscle aches, chills, and exhaustion that classically will precede the emergence of the rash. So really right now, anyone that's particularly in the risk community, and I named that before, if they have any lesions, any concerning lesions that they're not aware of why they are there, that they're concerning or new for them, they should not have any further intimate contact with other individuals and go seek medical attention immediately. Most clinics and hospitals in the state have the ability to easily swab and test for the monkeypox virus. We maintain a 24-hour, 7-day-a-week infectious disease hotline. That's a resource for clinicians, for doctors and hospitals to call us to talk through cases and to help get people tested if that testing is indicated. And one additional development this week is large national reference labs like LabCorp and Quest are going to start offering testing as well. Before that, testing was limited to state Office of Public Health labs, our lab in Baton Rouge, for example. Going forward, hospitals and clinics will have the opportunity to get their patients tested directly through the lab that they work with without having to go through the state Office of Public Health labs. So all of that is encouraging. I'm going to pause there. I'm going to ask Theresa Sokol to talk a little bit more about our numbers and what typically happens when we have a case or an exposure and what's happening right now. And then we'll pull it back, say a couple words about COVID, and then we'll be happy to take any questions that are out there. Theresa.
Thank you, Dr. Kanter. Can you hear me?
Loud and clear.
Okay. So just to recap, we have identified 2 cases through our state public health laboratory here in Louisiana. One of these cases, as Dr. Kanter said, was among an out-of-state resident who was visiting Louisiana. The other case, the one that was most recently identified, is in a Louisiana resident. We presume that there are many other undetected cases for all of the reasons that Dr. Kanter stated. This monkeypox infection and the clinical presentation that we're seeing in the current outbreak can mimic other infections. And so some clinicians may not think that they need to test for monkeypox. depending on the symptoms that the patient is presenting with. And sometimes the symptoms are so mild that a patient may in fact not present for a medical evaluation. And so these cases are going to be undetected. I do expect that with increasing awareness, both in Louisiana and nationwide, as cases continue to increase on a daily basis, that we will continue to identify additional cases here in Louisiana. And that's especially true as testing capacity increases. As Dr. Kanter mentioned, LabCorp now has the capacity to test for specifically for non-variole orthopox, but that's going to tell us essentially whether or not there's a monkeypox case. And in the coming days, 4 additional large reference laboratories are going to also be able to have the availability to test for monkeypox as well. And so we certainly expect, and we have mechanisms set in place in order to receive immediately the reports of any tests that are positive from other laboratories as well. So we will be receiving the information about Louisiana cases that may be tested at one of these sites. Testing availability will still be testing capacity will still be available through our state public health laboratory as well. We will still be providing that service. So I do want to talk a little bit about what happens from an epidemiologic, from a public health standpoint. Really the purpose is to contain and prevent additional transmission. We do this through early case detection and through containment measures. And specifically in this case, it's monitoring for symptoms and also offering post-exposure prophylaxis when it's necessary. So I'll go into a little bit more detail about that. How do we detect cases? How do we try to get these cases identified very early? Because the earlier we identify cases, the more effective our prevention measures are going to be. This is the reason that we provide information to clinicians. We have sent out health alerts to let clinicians know what they need to look for, when they need to test, how they can test, as Dr. Kanter said, how they can contact us, because they're really, the providers in our community are really going to be the ones who are going to be able to quickly identify and then collect specimens and then order testing to really be able to identify these cases. And part of early case detection is also providing information to the public, which is one of the reasons we wanted to have this briefing. It's really important for patients to know what the risk factors are that make people more likely to be exposed to monkeypox, and also what signs and symptoms to look for so that they can seek care if they're concerned that they may be infected with monkeypox. Now, once we identify a case of monkeypox, the next steps are related to that containment piece that I mentioned. We do that first. Number one, I'll talk about monitoring. We do that through monitoring, and I'll just note that quarantine of contacts that are identified is not part of the general recommendation for monkeypox. What we do is we will reach out. First of all, we're going to interview any patients that are positive, and we're going to collect information about people that may have been exposed during that patient's period of infectiousness. We will then reach out to those contacts that have potentially been exposed, and we're going to let them know about the exposure. We're going to provide information about the signs and symptoms that they need to look for, and we're going to enroll them into a monitoring system. We're using what's called TIMS. It's a CDC system for text-based illness monitoring, and it's very easy to use. It's been very well accepted by the folks that we've enrolled so far, because they simply get a text message every day that asks if they're experiencing signs and symptoms. It reminds them of the number for the Office of Public Health that they need to call if they do experience signs or symptoms, so that we can help facilitate testing and medical evaluation. And then the period of monitoring lasts for 21 days after exposure. Again, it's very simple. It's non-invasive. It's a quick text every day, and folks seem to be able to very easily respond. It's been very successful so far. So there's another component to containment, and that is post-exposure prophylaxis. So the vaccine, and specifically the vaccine that we're really referring to for all of this, is called JYNNEOS. And JYNNEOS can be used as a post-exposure prophylaxis. If it is administered within 4 days of exposure, it can help prevent illness altogether. If it's administered really between 5 and 14 days, somebody may still develop symptoms, but the severity of those symptoms are going to be greatly reduced. So the people who are candidates for this vaccine as post-exposure prophylaxis are those that have had exposures that are considered to be high risk. So when we're interviewing the patient and we're talking about people that might have been exposed, we talk about exactly what the type of exposure is. We're able to assign a risk classification. It's going to be either high risk, intermediate risk, or low risk. High risk, for example, is going to be someone who had unprotected skin-to-skin contact with a patient while they were infectious and while lesions were present. An intermediate risk, for example, might be someone who was within 6 feet of an infected individual for more than 3 hours. Again, it's much less, monkeypox is much less transmissible, for example, than COVID. So rather than the 6 feet, 15 minutes, we're looking at 6 feet for 3 hours. And this would be when neither individual that either the case or the person who's being exposed, if they're not wearing a mask, that would be considered an intermediate risk. If someone, if a patient is within 6 feet of another individual for less than 3 hours and neither one are masked, that's considered a low risk. So generally what happens, someone with a high risk is offered post-exposure prophylaxis. It is enrolled in our monitoring system. Someone with an intermediate risk, depending on what the risk level is and what the benefits might be, we may or may not offer post-exposure prophylaxis. That's where there's a little gray area. For someone with low risk, post-exposure prophylaxis is not warranted. And so what we usually do is simply enroll them in the monitoring system. Again, right now, just so you know, we're monitoring between 15 and 20 individuals that have been identified as contacts that were exposed to someone, either one of the 2 cases that have been identified while present in our state, or cases, Louisiana residents that might have been exposed while traveling to another jurisdiction. And we have administered between 5 and 10 doses of the post-exposure prophylaxis. I think the last piece that I wanted to just touch on is, what are we going to continue to do now? Continued vigilance is really important. We need folks, especially those who are at higher risk for exposure. As Dr. Kanter mentioned, right now in this epidemic, it's gay, bisexual, or other men who have sex with men, specifically those who have multiple sexual partners or they have anonymous sexual partners. Those are the folks right now that are higher risk, although anyone can get monkeypox. And the epidemiologic picture may change throughout the course of this investigation. We need providers to continue to be vigilant and to be thinking about monkeypox when they're evaluating patients with rash illnesses, and to test when it's warranted. We're going to continue to make requests to make sure that we have vaccine on hand to provide post-exposure prophylaxis for high-risk exposures. And then as vaccine availability is expanded, then we will also expand our post-exposure prophylaxis program to include not just those who have known exposures, but potentially those who may have had unknown but likely exposures as well. So lastly, I'll just mention a little bit about reporting. Of course, right now we want to make sure that folks in Louisiana have the most up-to-date information about the cases that are occurring in Louisiana. So we will continue to provide that information. We'll most likely, once we start to see fairly consistent increases over time, which I mean, for example, daily, every other day, which I certainly expect to happen, we will post this information on a dashboard so that people don't have to submit inquiries every day. They'll be able to go and look and see what the current case count is. And we expect that we'll update that every weekday for the foreseeable future until reporting changes into a more routine and sustainable sort of system. The other piece that I wanted to mention, I know a lot of folks have questions about specific patient characteristics or demographics. We will not be reporting those. We won't be reporting any information about patients other than the LDH region in which the patient resides, or if it's a patient from out of state that is identified here, perhaps where that individual was located when they were identified as a case. Any other information, age ranges, median age, geographic distribution, sex of the patients, we're not going to report that information until case counts are high enough that patient confidentiality will not be compromised. So certainly we know that all of this information is important to the epidemiologic picture of the outbreak, but we do need to have higher case counts in order to preserve patient confidentiality before we provide that information sort of broken down more granularly. So that's definitely planned in the future. I just wanted everybody to know that. And just so folks know, CDC has done the same thing. They waited until they had a certain number of cases before they provided that breakdown, and we intend to do the same thing for the same reason. So I think those were all the points that I wanted to cover. So I'll turn it back over to Dr. Kanter for his brief COVID update.
Theresa, thank you so much. I'll be very, very brief. I just wanted to say a couple words about COVID, specifically because we are in a surge right now. And this is our 6th COVID-19 surge of cases. Today, we reported just under 5,500 new cases. We reported 2 additional COVID deaths. We have 567 people hospitalized and COVID positive in hospital beds throughout the state right now. And this week, percent positivity continued to increase, up from 19.6% of all tests coming back positive to 23.7% of all tests coming positive. And we widely acknowledge that our case counts right now are a vast undercount of the true amount of COVID out there. And that's because so many more people are testing at home with a rapid test, and that's a good thing. It's a good thing to have easy access to testing. The idiom that we use is we don't need to count every raindrop to know when it's pouring. And by every measure, there is a lot of COVID being spread right now. So on one hand, we continue to be in the middle of a very large surge of COVID-19 being spread in Louisiana. On the other hand, there's a marked difference between this surge and prior surges. And that's that on average, people are not getting as sick as they had been with earlier surges of COVID. And there's some reasons for that. This particular variant that's circulating right now, and right now the BA.4 and BA.5 subvariants of Omicron are the dominant strands both here and nationally. They are less virulent, less damaging as earlier strands are. And we as a community have more protections in ourselves. About 95% of the state of Louisiana is either vaccinated or had COVID in the past, or both. And while none of those are 100% protective, they certainly are significant to some degree. So while our hospitalizations have been going up, and they've more than doubled over the past month, at this point in time in prior surges, we would have had 2,000 or 3,000 COVID hospitalizations. And we have 567 right now. So on average, the acuity is less. It's important to remember that that's on average. And unfortunately, we continue to report new COVID deaths every day. Today, we reported 2 new COVID deaths. Yesterday, we reported 3 new COVID deaths. And unfortunately, there has not yet been a day of COVID-19 reporting in Louisiana where we were able to say 0 new COVID deaths. We're all very much waiting for that day to come. It hasn't come yet. So the message is this: on one hand, there's a lot of COVID out there being spread, and the risk of being exposed to COVID is high in every part of the state right now. And while on average, these cases are mild, that's not absolute for everyone, and particularly for people that have higher risk, people who are of an advanced age, people who have significant underlying comorbidities, specifically people who are immunosuppressed, they continue to be at elevated risk, and they really should be considering extra precautions. It's important for everyone out there to be fully vaccinated and boosted if eligible, and folks should make a risk determination for themselves. If they deem themselves to be at higher risk, or they want added protection for themselves, there are easy things that families can do right now, like limiting their exposure, being judicious about indoor settings that they go, and wearing a high quality mask like an N95 or a KN95, which are very easily accessible now. And that's something that just wasn't the case at earlier points in the pandemic. So I want people to understand we are in a surge right now, cases are high. While we are thankful that on average, people are getting only mild disease and our hospitals are not at risk of being overwhelmed right now, and we're thankful for that, that's unfortunately not true for everyone. And people need to take stock of their own risk and take added measures to protect themselves if they so choose. I'm going to pause there. I'm going to turn it over to Michelle to help us through some Q&A, and Theresa and I will be glad to stay as long as it takes to answer as many questions as we can. Michelle?
Thank you, Dr. Kanter and Theresa. We will open the floor up for questions now from reporters. As a reminder, only members of the working press are allowed to ask questions, and you can put your name and media outlet in the chat and you'll be able to ask your question live. So just put your name and media outlet in the chat and I'll call on you, and you will also have to unmute yourself. Our first question will come from Emily Woodruff, the Times-Picayune and the New Orleans Advocate. Emily?
Hey there, thanks for doing this. I'm curious about how many vaccines Louisiana has on hand and how many you expect from the federal supply. And then I'm also curious about the number of negative tests that have been done.
Thanks, Emily. That's a pertinent question. I'll talk about the vaccines, then I'll ask Theresa to comment on the number of tests that have been conducted. We initially received 20 doses of vaccine from the CDC, specifically to be used in post-exposure prophylaxis for people that were exposed to but had not contracted monkeypox. It's a relatively small number. The CDC's supply is limited. They initially had 75,000 doses of the Jynneos vaccine, which is the preferable option of the two vaccines that are out there. The CDC did announce a week or two ago that they were expanding their monkeypox program and proactively allocating vaccine to a number of states. Unfortunately, Louisiana did not get allocated vaccine in that round because we had no identified cases at that point in time. We expect, certainly hope that will change soon. When it does, it will open up the opportunity to expand the number of people that we're able to vaccinate, perhaps even to do pre-exposure prophylaxis. And we're waiting on the CDC to make that allocation right now. Theresa, you want to comment on the other part of that?
Yeah, I don't have the number of negative tests off the top of my head because we've been done actually over the past few days. We've increased, we've been testing every day, but I can get it for you. If we go on to the next couple of questions, I'll have the answer for you in just a few minutes.
And then I'll also flag on that, Emily, once more clinicians access testing through the commercial entities, once the avenues for testing to LabCorp and Quest get fully opened and used, we will unfortunately lose some visibility on how many tests have been conducted because it won't be coming directly through the OPH lab.
Okay. Thank you, Emily. The next question is from Wally Pierce, KADN News 15.
Thank you. I actually have a few questions, if that's okay. The first one, that Dr. Kanter mentioned just a moment ago that there are more than one vaccine for monkeypox. I read this morning on Twitter, take that for what it's worth, that at least one of them is also the vaccine that's used.
Walter, let me just stop. I can barely hear you. Could you mind speaking closer, or just speaking a little louder if you don't mind?
Yeah, I'm sorry. Can you hear me better now?
Yeah, that's better. Thank you.
I'm sorry. One question was I saw on Twitter this morning, take that for what it's worth, that one of the monkeypox vaccines is the same vaccine that's used to prevent smallpox. Is that true?
They both are, really. The viruses themselves are cousins. So there's two pertinent vaccines out there. There's Jynneos, which is the newer vaccine, and there's ACAM 2000, which is the older vaccine. both of them have indications for both monkeypox and smallpox.
Okay, thank you. And so my next question, I'll just kind of combine two and throw it out there. Many of the symptoms of monkeypox, they sound similar to flu and COVID. Is the rash the most reliable indicator, coupled with those other symptoms, that it could be monkeypox? And how does the transmissibility of monkeypox compare to the coronavirus?
I'll take the latter part first, and then I'll ask Theresa to add anything else that she would to it. Significantly less transmissible. COVID, for example, is primarily spread through the air to people, through respiratory means. While it technically is possible to transmit monkeypox through the air, through respiratory secretions, that's not the dominant mode of transmission right now. The dominant mode of transmission right now is person-to-person contact, physical contact, oftentimes during sexual activity, but not always. But that's how this outbreak is being driven right now. It's significantly less transmissible than COVID is. That's one of the reasons why I said, listen, this is not COVID. It's not Ebola, so to say. Oftentimes the lesion is the thing that would prompt somebody to go get testing. And with the majority of cases now, it's really the lesion in the context of some risk profile, known exposure or behavior that fits in with the risk profile, although that's clearly not 100%, that's not exclusive. And I respect that distinction to get even less as the outbreak grows. Theresa, what would you add to that?
I guess I would just add a few details. I like to compare how close contact, in the absence of direct skin-to-skin contact between COVID and monkeypox, constitutes an exposure. So everyone knows for COVID, you're considered to be exposed if you are within 6 feet of an infected individual for at least 15 minutes. And masks are not taken into consideration. And that's because COVID-19 can be spread. It really is a respiratory illness, and it can be spread through much smaller respiratory droplets than monkeypox can. Monkeypox is spread through much larger droplets when it is spread through the respiratory route. And oftentimes that's more likely if someone has lesions inside their mouth as well. And so those larger droplets, they cannot travel as far. They're not going to be suspended in air. It's really going to require, for that sort of transmission, prolonged face-to-face contact. So for that sort of exposure to occur with monkeypox, the infected individual and the person who's potentially exposed would need to be within 6 feet for 3 hours or more, and they would both need to be unmasked in order for that to constitute an exposure. So you can see that it's very different in terms of how easily COVID is spread, and how much compared to monkeypox, how much more easily COVID is spread through that respiratory route compared to monkeypox. And I will also add that I did get the information back from my team. It looks like this is approximate. It looks like about 30, maybe 30 to 40 tests, certainly less than 50 though, but between 30 and 40 folks have been tested that were negative so far at our state laboratory.
Any other questions? I don't see any in the chat. Any other questions from anyone? If not, I will turn it back over to Alan.
Thank you, Michelle. Thank you, everyone. We hope that this has been useful. We know the public undoubtedly has a number of questions about monkeypox, so appreciate your help, making sure folks are aware of the situation, as well as our guidance for anyone with concerns. If you did not get your questions answered, you can follow up with me or a member of my team. I dropped a link and some information in the chat. There are a couple of helpful links in the press release. We try to focus the press release on questions and answers we think that many of your viewers and readers might get, but please do send your questions to us if they didn't get answered. And just thank you again for joining us. We are aiming to get the recording uploaded onto YouTube in the next half hour. So thanks everybody, y'all stay safe.